what's important to know about this CME, for those of you who want to spread the word, is we're going to be recording this CME, and all of the Waterbury Hospital CMEs moving forward will be recorded and will be available on our hospital website under emergency department, under EMS, and there'll be a library of recorded CMEs that you can watch and get CME credit for. And you'll get a certificate sent to you as if you attended the live CME. So we're working on that now, and that should be live within the next couple of weeks. That should be live on our website. So all CMEs, whether they be virtual like this one or in the Pizzazro as we're normally accustomed to, will be recorded, edited. Any PowerPoints or whatever will be embedded into the CME and into the video, and then we'll make them available for those who couldn't make the CME or who may have to have left in the middle of it, like some of the crews have to leave in the middle of the CME, and then they take a brief exam, and then they'll get full CME credit for the course. So stay tuned for that. So without further ado, I'd like to introduce our Vice President, Senior Vice President and Chief Operating Officer of Waterbury Hospital, who really kind of guided us, the entire organization, really through all of COVID-19 and integrated very well. So this is Mark Holtz.
Thank you, Jeremy, and welcome everybody. It's really a pleasure to be able to present this to you. I will confess a little bit around my age. I've been in healthcare administration since 1979, which makes it about 41 years. And for me, I've never experienced anything like this in my entire career and my lifetime, and I don't think that any of us probably have. So, it was a great experience. I think that for a lot of us that are in healthcare, it's almost kind of why we got into this in the first place. I want to acknowledge, before I get started, the amazing and integral role that the first responder community had with us in all of this. You guys are guys and gals and professionals that were really heroes on the front line. I think I commend everybody that's worked through this, and I want to thank you for your service. Before I get started, I think we're all partners in this, and I've said this in every forum that I can, that we can't do what we do in here without what you do out there. And in a lot of ways, you were, as the first line out there, putting yourselves in harm's way every single day, and I want to thank you for that and commend you for that. I'm going to bring up the presentation now. I want to make it that please stop me at any time during the presentation as we go along if you've got any questions. I'm going to integrate as much as possible our experience here at the hospital and kind of mention, of course, how the interactions had occurred within the EMS community as well. But I thought that giving you the perspective of what we were dealing with would be important. I'm going to start with a little introduction about myself and about Waterbury Hospital. I want to just talk a little bit. I got one slide to talk about COVID-19 itself and the SARS coronavirus. I'll take you through sort of an emergency management outline that starts with planning and mitigation. And we'll talk about what some of the key processes were, what went well, and what we think we could have done better. The next phase from the planning and mitigation was then managing the surge and what happened at the height of the surge here, which took place really for us in the state of Connecticut and at Waterbury Hospital, occurred somewhere between April 16th and April 21st. I think our peak at Waterbury Hospital was on the 16th of April, and the peak in the state of Connecticut was on the 21st of April. I wanted to take a quick look back over the last couple of months, where we are now, and then quickly talk about lessons learned, and then take some questions and do some, sort of conversation at that point. So, introduction, I've been at Waterbury Hospital for about 5.5 years. I've been through a lot of transition here and change at Waterbury Hospital. I think I would say that I was probably here 5 minutes when Jeremy was at my door saying, we've got to do everything we can to make sure we have very good and tight relationships with the first responder community. And we got out to a lot of the EMS squads, the firehouses, and the police department to make sure that we built that relationship. And that was my experience in other markets where I've worked. Waterbury Hospital itself in 2016, in October of 2016, was acquired by a privately held for-profit company called Prospect Medical Holdings. And, that acquisition by Prospect was a great thing in the life of Waterbury Hospital. We had been struggling, no access to capital, we're losing money, and what Prospect brought to us was stability, an infusion of cash to enable us to be able to invest in capital in the buildings and the equipment that we have. And one of the reasons I bring this up is because one of the great things about being part of a big network was that during the whole COVID experience and the surge, we started early on, really while there were still no patients in the United States, and this was looking over to China and seeing what was happening over there, and put some communication together that was corporate. And ultimately, and I'll talk about this as part of our the outline that I'll discuss today, that a group of all the COOs from the 20 hospitals across the country would get together. During the height would be every day, then 3 times a week, and today it's now once a week that we still talk, we still share. We've developed an early warning scorecard so that as we monitor what's going on and look at test positivity rates, we're prepared for whatever surge comes. The other thing is that we have hospitals in Prospect's network that are in not just Connecticut, but Rhode Island, New Jersey, Pennsylvania, and California. So around the LA area. So if you think about what's happening now nationally, we're still hearing from our hospitals in LA about what their experience is like. Having a hospital in New Jersey let us here in Connecticut really prepare for what was coming, more than you can imagine. The hospitals in Pennsylvania are in the Philadelphia market. So that was important lessons learned. And the hospitals in Rhode Island, sort of followed us in terms of the progression of the virus and where it went. So that's the introduction. Just a quick history of the coronavirus itself. As you well know, the virus itself is called a SARS-CoV-2. It is the virus that causes COVID-19. This SARS-CoV-2 is about 90% identical to the bat SARS that created SARS back in the early 2000s, and identical to the 82% identical to the human SARS virus that caused the MERS. As both the SARS-CoV-2 and the MERS were transmitted from bats to palm civets or dormitory camels and finally to humans, I've come to understand or feel that the SARS-CoV-2 that causes COVID-19 had the same progression. Many of the original patients worked out or lived around the local Hunan seafood wholesale market in Hubei province. This suggests that SARS-CoV-2 was transmitted from animals to humans, and most of the initial patients visited the fish and wild markets in Wuhan. This fish and wild market also sold live animals such as poultry, bats, marmots, and snakes. So while it's not 100% clear the role of the Hunan seafood wholesale market, it is pretty certain, as certain as you can be, that this was a naturally evolving virus that is very similar to other SARS coronaviruses that have occurred in our history. So I want to start by taking us through some of the planning and mitigation. So very early on, as I said earlier, while the virus was still in China and not yet hit the West Coast, we started doing some planning. One of the first things we did was training. Our infection control, our emergency management and education got together and were able to set up early trainings to prepare for the pandemic by retraining people on how to do donning and doffing of PPE. For many of you, you might remember that during the outbreaks that occurred around now I'm blanking. We did practice donning and doffing, to get ready. The training was set up in our auditorium, and what we did was, instead of scheduling the training, we actually just set up in the auditorium and asked staff to just show up whenever they could, and we wanted to encourage more people to attend. As you may recall, sort of early on, I think that there was a lot of, mixed messages in communication, even at a national level, about how real this was, how much we needed to prepare. But I think those of us in the healthcare community and the first responder community really took this very seriously and began to prepare donning and doffing. I do remember, and Ryan will remember this as well, and Jeremy, that the city of Waterbury, very early on, I was actually talking with the mayor today, pulled together a task force that included all the main first responders in the city, which included the teams at AMR and at Trinity Ambulance. It included the medical leads at both Waterbury Hospital and St. Mary's. It included those that were in the school systems, the fire departments, the police departments. The mayor had a representative there. Adam Renko kind of led that. And I think the good thing was we started to talk early on about identifying patients, protocols that we would have for the first responder community, how we would communicate what to do when you came upon a patient, and what to do and how to communicate with the hospitals about bringing patients in. We wanted, of course, to make sure that we were mitigating any risk and minimizing any risk to you as you encountered these patients, because we didn't really know what we were going to encounter. If you remember, in the beginning, it wasn't clear about asymptomatic transmission. So these were some of the changes that evolved over the course of time. Once it was clear that we did have COVID in Connecticut, we were able to move our training from the auditorium to HealthStream, which is our online training. And in addition to that, we actually had videos played on TVs that we have around the hospital and in other locations that staff would always have access to it. We developed signage that we would put on the doors that showed people how to don and doff PPE. Some of the things that we felt like we could have done better were making sure that the training was expanded to include not just the nursing and medical staff, but our environmental services, transport, security, and other non-frontline staff when there's an issue. And the other thing that occurred kind of early on, it was near the end of March, was once elective surgery got canceled and outpatient centers started to close down, some of the staff, particularly clinical staff, so we were looking to train every nurse that we could find, every doctor that we had, and some of them were furloughed but needed to be prepared to call back. And I think that we probably could have done better with the training there. In terms of patient identification, we quickly developed an algorithm that staff and providers would follow to identify who was a potential patient under investigation, and determine what isolation precautions would need to be, what testing, who would get tested. Testing back then was not widely available. It was really only the Department of Health. They had to approve. I remember early on, we had to call them. We had to tell the story of the patient, and they really had to approve whether they would allow us to send a test up there or not. Just think about now in retrospect how crazy that is. But the testing just wasn't available. The other thing that happened was we worked in terms of where we were going to place patients. We identified a unit, our Pomeroy 6 unit, which was a mothballed unit that we fit up for negative pressure rooms. But again, in retrospect, to think about it, that unit probably only had a third of the amount of beds that we would eventually need. And, I'll talk about this when we talk about lessons learned, that since that time, we've actually closed that unit and we've outfitted one of our large units. So we could now have, instead of having 18 patients with COVID in the hospital, positive COVID in the hospital, we have a unit that we can have as many as 34. So it's significantly increased, because the key for us in terms of patient identification, patient placement, and physical plant preparation was to try to have every one of these patients in a negative pressure room and minimize the risk of this spreading into other places. We did expand our negative pressure rooms. We went initially, we had built-in negative pressure rooms around 13. Today, we have 52. At the height of COVID, we were into the 40s, probably about 41. Our engineers, I got to tell you, they got really good at outfitting these rooms. We got these big HEPA units that we were able to put into the window, and they had this down to a science. We also installed what we call a safety net system, which was an excellent collaboration between our clinical engineering department, our facilities team, to wire this up. And what that did was it allowed us to take expanded sets of vitals and have it in the rooms, so we didn't have to keep traveling in and out of the rooms. And eventually we added something called Viewpoint. So just think of it as FaceTime, so that we could communicate with the patients without going in and out of the rooms. It was a way for psychiatrists and others to talk to patients. And the key here was we wanted to minimize the traffic in and out. In retrospect, again, a lesson learned here for us was that the number of these units was insufficient to meet the demand. And as we quickly found out, once people got used to what the technology was capable of, they kind of really, was in demand everywhere. In terms of surge planning, we went through a very rigorous process of identifying every location and bed that might be utilized. I remember walking around on a weekend here, looking at every single space where I could put a patient. And just to give you an example of what we were thinking, our census on a normal day, today our census is around 150. We have flexed up to be around 200 when we're very busy in non-COVID days. But we had identified the ability to go up to as many as 335 beds. We looked at our PACUs, we looked at our pre-op holding areas, we looked at the GI lab holding areas, every place where we would have a stretcher or could put a patient, we identified as a potential bed. And that was very important because the models, when we were looking to like what was the experience in New York and what was the experience in Italy, were very, very scary at the time. We didn't know what to do. So we had to plan for the worst case scenario. In terms of human resources and surge planning, we identified all nursing and medical staff who could become available in the event of the worst case scenario hitting. We had doctors that were working as medical doctors out in the community in our outpatient practices that became hospitalists, some that became ICU doctors. We had to look at the potential expansion of the ICU and the pulmonologist and who could help out there. This effort became important because we did have a small number of medical staff who became exposed, a couple who became sick. Overall, I would say our experience, because of, in retrospect, of the use of PPE and the careful planning that we had, it turned out that we tested about 1,500 employees, and a very small number. I think our test positivity rate with that was less than 1%. So, and that's pretty standard around healthcare, in terms of the number of people that were testing exposed and became sick. The next thing I want to talk about was PPE and other critical supplies. We never ran out of anything here. We made a lot of really good planning decisions, and this is where being part of a network like Prospect was very helpful. They thought well in advance about this. They started to put out orders and acquire supplies from everywhere in the world, including flying planes in from Malaysia with N95s and other masks, so that we could supply what we needed. I have to say, and Jeremy can testify to this, that the general public out in the community was unbelievable in the way that they were donating supplies. Some N95s, not a lot, but a lot of face shields, some gowns. I think every single day, the community came up with something. And Jeremy really was the point of coordination for all of that. It was fabulous. Another thing we had to do in terms of other supplies was look at things like our pharmacy inventory. Again, we didn't know early on. We had a sense of what drugs and pharmaceuticals we were going to need, but we had to take a very careful inventory. And then here again, being part of a large network, we had a buying power and system that could think ahead and prepare us for what was going to happen. What are some of the lessons that we learned was managing the PPE to make sure that it lasted. Early on, we ended up going through a lot of our stock too quickly, and we had to adjust on the fly. And I have to say that we were able to do that. I had a very good team around me of nursing leaders, emergency management, supply chain folks. We did some things inside the hospital, like create a PPE station for staff to get supplies as they were on their way in. Eventually, we went to a system where we were able to decontaminate and reuse N95s. We were prepared for a state of emergency on the state and federal level, but we weren't. I think that nobody was really prepared for this worldwide pandemic. And I think we're still feeling the effects of that lack of preparation, if you will, on a national basis. A more accurate inventory was developed, and ultimately, we think going forward to have that accessible in a database would be really very helpful. I put PAPRs on this list because what they are is air filtration systems that look like the spacesuit, if you will, that you put on. And this is for people who cannot wear an N95 for fit testing reasons. And we only had 10 of them. And 10 was nowhere near enough. And Ryan, was really the point person for all of that. I felt like almost every day somebody was saying that we needed more PAPRs. Staff were trained quickly and effectively on the use of the PAPRs, but they just weren't enough. We have since placed an order to get 20 more of them. So we're in a position now, if we get another surge in the fall, that we would be having enough. The other thing we found out that while we trained staff in how to use the PAPRs, the maintenance of them, the cleaning of them became a challenge, because if you don't clean them right, then the batteries don't work, and it creates another issue. I wanted to talk about traffic in the building. One of the things that we did around that was we also quickly looked at visitors, students, vendors. I wanted to share with you a grid that we put together where you could see the level 1 restrictions were signage requesting visitors to remain at home if they were ill, cough etiquette signage that we had up, stock and provide respiratory etiquette stations and areas. In a level 2, we went to restrict visitors to patients on isolation, only one designated support person, travel advisories for staff. We went basically right to level 2B, which was reduce the number of entrances or access, screen all visitors for travel history and symptoms. Once we found out about asymptomatic spread, a lot of that became moot. And really what we ended up doing was just screening around symptoms, taking temperatures, and providing masks. We were limiting one visitor per patient at the time, and then we very quickly, I think it was within a week or 2 weeks at the most, that we went to the level 3 restrictions, which were no patients or visitors. And you all knew that because you knew that when you brought a patient to the ER, that the people that were accompanying the patients couldn't come in. And it was tough. I have to say that it was one of the toughest things that happened as people in the hospital who really want to take care of our patients and understand the role of family members. It was very difficult. I know how hard it must have been for you because you sort of were bearing the brunt of this when the family members were complaining. Again, I just want to acknowledge the role that you played and thank you for everything that you did during this time. A couple other quick things. I talked about local government communication and the team that the city of Waterbury had put in. We developed some, just go to the next thing around communication. We had developed communication mechanisms internally, and internally was communicating with our corporation, with our corporate folks. There was daily emails that came out, and I went back and looked, and I saw it really started at the end of January. Daily communications that came out about the virus and how it was spread. We found out quickly that it was important to do local communications. Our CEO started doing a daily town hall at noon every single day, and then twice a week on the evenings. And we would get 30, 40, 50 people. They would ask a lot of questions. We would get a lot of great feedback. It was, I think the transparency and communication was critical. In fact, during the height of the pandemic, we had what we call a PPE communication board, so that when you came in and you got the PPE station and you got your masks, you knew that, whether it was red, yellow, or green, whether we were in critical short supply of something, whether we were in contingency position or whether we were in normal usage position. We had a weekly Q&A that went out. It was very, very popular with the employees. We were utilizing our Facebook pages and websites for external communication with the public. I think some nice things that happened when we had our first discharges, when we had our first extubations. We had probably 3 patients that I particularly remember who had been on vents for as many as 25 to 35 days that got discharged. And really it engaged the public in helping us in creating at least some good stories. At one point we developed a process where when a patient got extubated or went home, we would play Here Comes the Sun, and it really helped bolster the morale of the staff that were working every single day. In terms of testing, I would say this was probably our biggest challenge, and it remains nationally the biggest challenge that we have. We were the second hospital in the state of Connecticut to stand up a drive-through site. And again, I've got to give credit to a team that pulled this all together in a matter of 48 hours. And the state health department came over and they were very pleased with what we did. We got, they came out and made a couple of suggestions really, and within about 2 or 3 hours, we were up and running. I got to say that was enormous team effort to do that. And then eventually we started to plan for in-hospital testing. We went away from the state health department lab. We started using Quest, and we started using the Jackson lab out of UConn. But this was already weeks into the pandemic. The turnaround times in the beginning were 3 to 4 days or more. And what that did was it meant we were accumulating patients in the hospital, isolating them on precautions and not really knowing, whether they had the disease or they didn't. And it created a really untenable situation where the hospital really filled up. Once we got into a routine where we knew that it was going to be 24 to 48 hours that we could determine, it allowed us to much more quickly move these patients to a standard level of isolation or no isolation, and cohort the people who were really sick. Today we have availability of a machine called a Cepheid, which can do 2-hour testing. But again, we only have limited numbers of those tests, so we really use them to identify a very special population of patients who needs to get that short turnaround time. One example would be our behavioral health patients. We have to test them before they go up to the behavioral health unit. The last thing in the world anybody wants is to have an outbreak in our inpatient psych unit. So we test those patients before they go up, and that's one of the uses of the rapid test. The other today would be around surgical patients and surgical emergencies, traumas, and the like. And then last, I did mention a little bit about the community support. Again, shout out to our community who were just incredible with us. Just to show you, the other thing that we did is we have these predictive models. Yale Penn developed a model. We ended up ordering beds. We repurposed space for overflow. We looked at provider staffing, RNs, PCAs, which are our technical assistants, our respiratory therapists, and we ended up canceling all surgery. And you can see that the blue line, which was sort of the worst case scenario, was frightening in terms of the predicted numbers of admissions that we could have had. At some point, we knew that if it ever hit that, it was going to be bad because there was a limit to how much we could do in terms of getting the staffing predominantly, or the equipment needed to manage this. Okay, so the management during the surge, talked about the organizational and corporate structure and the command centers that were set up. I think in the height of the pandemic, that communication, we had 3 different groups set up. One was a CMO and medical leadership group. So all of the medical officers around the country got together to talk about medical protocols, testing protocols. We needed medical advice about PPE. We needed medical advice about, treatment plans, and what was the best thinking. And Dr. Lundby, who's our CMO, was really one of the ones who was leading this group, along with the corporate CMO. It was a very important functional piece that informed the rest of us. The incident commanders and COOs had a group, and we would meet daily. And the CEOs had a group, and they would talk about more strategically what needed to occur. Internal communication, we started doing senior leader rounding. I talked about the daily CEO town halls that happened. We also got into weekly meetings with our unions because we felt that we wanted to stay ahead of any issues that might arise. And it became a very collaborative and very helpful approach to things. It really helped us a lot. One thing I just want to talk about the senior leader rounding for a minute. We were really mixed about, I like to round every day on our units. I go and walk through the floors. Early we felt like, were we putting ourselves and others at risk by doing that? But we quickly found that when we were out there, the staff appreciated the presence, the support, the ability to give us feedback and have interaction. And so we thought that as senior leaders, we had to be there. I was in the ICU almost every day, in the ER almost every day, up on the COVID unit, just to make sure the staff knew that we were there to support them. We started making rounds to provide snacks for them and food for them because of how hard everybody was working. Let's see, the surge implementation I talked about. We ended up surging and opening an additional ICU. Our ICU can go up to about 28 beds. At our height, we were at 35 beds. One of the nice things is, so we took one of our recovery rooms. We have a secondary recovery room. We opened up and created what the staff affectionately called the COVID Cove. I think the nice thing about that was because it was one big open room where we had negative pressure created, staff were able to get in their PPE once and stay in it all day, and so, as opposed to changing every time they went in and out of a room. But the sickest of the sick COVID patients ended up in the expanded ICU. But we had it open probably for about 2 weeks, 2 to 3 weeks, I think. The Pomeroy 6 unit I talked about with the automatic PO2 monitoring and blood pressure monitoring. In terms of PPE and critical supplies, I talked about the PPE communication board. We looked at screening employee issues, screening for employees. We staffed without really using excessive labor. Even today, we still have all of our main entrances are monitored by security who asks screening questions, takes questions, hands out masks. But we were one of the first hospitals in the state and the first hospitals in our system to mandate masks for everybody internally. And I think it really helped us. As I said, our test positivity rate in retrospect was really very, very low. We also did a lot in terms of caring for staff. We developed a caring call that took place so that staff that were having emotional issues and needed a place to ventilate and talk had a private opportunity to do that. We ensured compliance with everything by limiting access to the building, and our service was never interrupted. You know, thermometers, simple things like thermometers, kind of became a challenge. Other management during the surge, we created emergency response kits. As you can imagine, there were a lot of internal codes, rapid responses. We developed a kit that they could bring with them to the rapid response. It contained everything they needed, including N95s and shields and anything else they would need. We worked very hard to make sure we could take care of patients and not put ourselves at risk. We did develop an ED triage tent. Again, this one was even better than the testing tent. The state came out, and within about 2 hours, they approved us right on site. And a great teamwork. One of the problems was that it was in the middle of April at that point, and we had some really bad weather, high winds, terrible storms. That external triage tent really wasn't used as often as we probably could have. But one of the lessons learned there was, I don't think we would do it the same again. I think we would, do a different kind of a tent and also a different way of delivering that service. We had a whole process for dealing with end-of-life issues, as you can imagine. During the course of the pandemic, we had about 57 deaths, and there were times when our morgue was clearly overrun. We had to get a special trailer and work through a special process. And the other end-of-life issue that we faced was that the funeral homes were not taking these patients very quickly. So it did lead to the stacking up. We started to have limited visitor visitation occur because we knew that that for some end-of-life decisions, particularly in the ICU, it was important to have family to come. I witnessed some awful things happening with patients being coded in the ICU and families not being allowed to be there, and the staff, kind of FaceTiming. I don't think there's anything I ever thought I'd ever see in my entire life, and it's something that will stay with me forever. We did some things around helping to get patients out, modifying our Be Well bus, so that external transportation. We developed some telehealth platforms for the outpatient so that we could maintain care in the community. And our telehealth visits went from, a very small percentage to as much as 50 to 60% of the visits we had in our cardiology practice and our primary care practices became telehealth visits. And then the pharmaceuticals I talked about, everybody knows about hydrochloroquine. At our height, we had, maybe 15 patients on it. But as you've all heard, we found, and our doctors found, that it really wasn't effective. Today, we also use convalescent plasma and are in a study with the Mayo Clinic about that. And today we have remdesivir and enough doses to take care of many patients. Our census today is very low, and so we have that on stock in case we need it. So I wanted to do a quick look back and talk about sort of where we're at, where we are today. Through July 22nd, we've admitted about 295 COVID-19 positive patients to our facility. We're one of the higher and busier hospitals in the state when it comes to that. We've successfully extubated 20 patients. We've discharged 236 now COVID-19 patients. You can see the tracking, the volume. The blue line is the COVID positives, and the gray line is the combined. And as you can see, it was sort of the middle of April when we hit our peak, and it was close to 90 patients when you look at the combined number of PUIs and positive patients, that took up, I would say, 75% of this hospital. Today, we have 2 patients in the hospital. It is a miracle, not a miracle. I think it's a lot of hard work and a lot of good things that happen in our state. So some of the lessons learned, just quickly go through this. Patient placement is important, the negative pressure rooms and being prepared. I mentioned earlier that we had really now moved the original COVID unit that we had to another unit and prepared ourselves for a surge now. Our surge ICU, we've practiced that now, and it's almost like, I know you guys know this, that when you drill for something and then it happens, you're prepared. I know that the opening of that surge ICU was a little bumpy back then, but we have it down and we know now what we need to do. The lesson about testing, I talked about the inadequacy in the beginning, the identification of who needed it. I think that today we're in a better position, although it's not great. And I can tell you that what you hear about turnaround time, particularly for routine in the community, it is about, with Quest, it's about 7 days. It had been down to 48 hours. I think that what's happening nationally has really affected that turnaround time. I talked about our triage tent, how we would do that differently. PPE, the lesson that we learned there was to quickly go to preservation practices. We've maintained those preservation practices, and we're always talking about the preservation practices. So we can't keep our eye off that ball, because if we hit a surge again, I would tell you that the PPE that's out there, it's not plentiful. It's still not plentiful. And while we're preparing for a surge, depending on how much of a surge we get, those preservation practices are going to be critical. In terms of staffing, the lessons that we learned, I talked about too, preparing for any furloughed staff to get training before they come in. We did some training sessions, but I think that we would do it better and differently back then. Communications, that was the lesson learned here, was you cannot over communicate. You just can't over communicate. I would say that, every single day we had our regular safety huddle, we had a COVID huddle, we had town hall lunches, CEO town hall meetings, and evening meetings. And I think all of that was very, very critical. And then, the ED, one of the lessons that we learned in the ED would be creating more negative pressure rooms in the ED. I think, one of the things that I would like to hear when we're done, when you ask the questions, would be any feedback that you can give us about the ED. But I think that given what we were dealing with, our ED volume dropped. Our ED typically would see somewhere around between 130 and 135 patients a day. In April, that dropped to 63. And so, but it seemed like almost every one of those 63 patients was a PUI. We had to don and doff. We had to learn about cleaning. We had to, very rigorous practices in the ED. And I think what we're preparing for now, because we're going to be renovating our ED and building a new one. One of the things that we've built into the new plans that we've learned out of this is a whole negative pressure zone, so that similar to what I described about the ICU, the surge ICU, if you create a negative pressure zone in the ED, then you're not donning and doffing every time you go in and out of the room. You can go into a zone and go into your PPE once and take care of as many as 10 patients. So with that, I will stop talking now, and I will really take any questions or thoughts or feedback or anything that anybody would would want to talk about.
Hey, Mark, it's Ryan. Quick slide.
Yeah, hi. Hello?
It's Ryan. I'm going to put up
I'm sorry, you're going to put up what?
just a quick slide.
Okay.
Possibly, if I can hear. Well, it's not working, but I was going to say if the group can kind of talk about things that went well for them on the EMS side, like you said in the ER, if they had any concerns, if PPE, I know that we're trying to put some stuff over at the door if there was issues with that or any protocols. Just announce it so that we can add it to a list. I'm going to write up a big, huge thing afterwards so that everyone can see it. And we'll send it out to everyone, a little after action report, just so that for the future we're ready to go and we could look back on it and have an idea of the things that we may have missed.
So does anybody have any questions, thoughts? I'd love feedback about what you heard or anything, anything that we talked about.
Here, I have something, Mark. This is Jeremy. So one of the things that I was going to mention was that, early on as this thing was all unraveling and we're all learning new things, as the EMS community, really came forward and it's like, you need to talk to us about, what it is you want us to do. And we sent out a number of communications to our EMS partners answering their questions. But one of the things that was very clear was, as things were changing and as policies and protocols and practices were changing, it was incumbent on us to make sure that we kept ahead of it with our EMS partners. And I want to thank the EMS folks from all around, from both inside the city and then even the smaller towns who are saying, hey, how do you want us to come in? What do you want us to do? Do I put a PET mask on the patient? Do I put a mask on myself? Am I aerosolizing, nebulize, am I nebulizing patients? Am I ventilating patients and things like that? And so we had to work those out early on, but there was a few days that there was a little bit of confusion, and that just caused some anxiety for our EMS folks. And so I really appreciate them coming forward and saying, let's dial it back here a little bit and tell me what it is that you want. What is it that we want to do? And from a medical control perspective, we worked very closely with our partners across town at St. Mary's, and we wanted to mirror our medical control, our protocols in terms of nebulizers and bag valve masks and all those things that we were doing, so that there weren't two sets of standards. So just a thank you to the EMS community for coming forward and saying, we want to work together on this, but tell us what exactly it is you want us to do.
Yeah, that was important, and that's what that city group was put together to do, so that Dr. Jacoby over at St. Mary's and Dr. Akinili, who was our medical control here, talked frequently about these things. But I do agree with you, Jeremy. I think one of the lessons that we learned was, we could have done a better job at this. There were a couple of days in there where things were a little dicey, but I think we got on it and we worked it out. But that is something that any thoughts that anybody in the audience has for us would be, to make it even better, would be helpful. Well, you guys are awfully quiet. You guys are awfully quiet.
I see that Paul Rabouf is on. Is anything, Paul, from from the public health perspective?
So hi, Jeremy. I was just about to, raise my hand and want to reach out to you. So I still do EMS work, but I'm way out in North Canaan. And, going to a trauma center, it was just a few months ago, I had to take a trauma patient to Waterbury Hospital. So when you think of what we do regionally, I think there's a lot of improvement we can do on a regional level. So what the information you were sharing your EMS providers, as I'm taking my notes in hindsight, perhaps how could we share that same information to other EMS providers that aren't on your list because they don't go to your hospital a lot? And this just isn't for Waterbury Hospital. This applies to the other 5 hospitals in Region 5. So ChemSab has a subcommittee working on COVID, and I'm going to be part of that. And I jumped on board for the communication piece. So I'm taking notes because I'm particularly interested in communication. And Ryan Crichton's on the call as well. So as the co-chair of the ESF 8, one of the things we're going to do is revise the FERP plan. And I've got a lot of ideas with communication. And I've already kind of been in discussion with Ryan and how we can make communication better. So it's not just information, it goes beyond information sharing. And really on an ESF 8 level, which is all public health, acute care hospitals, EMS, behavioral health, long-term care, nursing home care, all these different people, there wasn't like a unified command or joint information center on the ESF 8 level. So I see some things that we can improve on. So I'm kind of rambling, but I think you might get a gist to where I'm going with this.
Yeah, for sure, Paul. I think Mark can chime in on that, but I think that now that we are kind of unraveling this, if we utilize our ESF8 connections more regularly, that would definitely spread the word a lot faster.
Yeah, I would agree. And I get one of our guests in the chat had stated that they work across multiple areas and every hospital had different policies. It was difficult to keep track of which hospital was doing what, and maybe some coordination in the state around some of these policies would, to streamline it, would make it better. I think utilizing that ESF, the statewide emergency management system would be helpful to give the hospitals the feedback. I think a lot, as I talked to my colleagues around the state, there was a lot that was similar, but there were nuances for each hospital that I think are sort of where that comment is very helpful.
The other thing I'll just comment as well, and I can't speak about my experience at Waterbury Hospital because I didn't have any during COVID, but initially I was looking at a lot of the guidance coming from hospitals, and this is in the early stages when OEMS was saying, hey, you're already prepared for this because you're supposed to have PPE and treat this like the flu, but this really wasn't the flu. And as we got information, as we learned more about COVID-19, we realized it was much more serious than the flu, and it wasn't your standard PPE. But what I noticed was that the protocols really didn't, and the guidance coming from some hospitals in the beginning weren't protecting or helping EMS provide patient care. They're more about protecting the hospital, their infrastructure, and their employees. And I can only speak to one email that I got from St. Mary's, and I'm glad you guys partnered with St. Mary's on your practice, because the guidance I got from Dr. Jacoby was, using LMAs instead of endotracheal intubation, holding off on aerosol treatments, and it not only helped us with patient care, but it also helped protect the EMS providers. Then weeks later, OEMS came out with their COVID-19 policies or protocols. And then other hospitals were able to share that information. But looking back, I wish we were a little quicker with that kind of advice and guidance. And kudos to the Waterbury area for really leading that. And the other comment I want to talk about is Waterbury. Adam Rinko really did a great job of pulling everyone together. So I saw some great plans coming out of Waterbury and that whole area, and people, there was good communication, good partnership. So kudos to all of you out there.
Yeah, I had mentioned that in my presentation that I found that when Adam at the direction of the mayor pulled that group together, it was very early. We hadn't seen one patient in the United States yet, and we were already discussing this. And that policy around LMAs and nebulizers, that came out of the communication that was occurring with that group. So yeah, I couldn't agree with you more. Kudos to Adam for pulling that group together and the mayor for thinking about it. I think it was excellent, excellent. Anybody else have any questions or any thoughts or any feedback? This isn't usually a quiet group.
So, Mark, I have a question. It's Justin.
Yeah.
So a few times brought patients into the hospital, and there was a traffic jam going up the hill there due to the testing. Is there any consideration about moving the testing tent away from the ambulance entrance?
Yeah, we
to
mow
the
that
point where
over.
I had to
What's
hop
that?
a curb to go around. I had to go up on the curb to go around a cone that had been moved in order to get in.
Yeah, I'm going to say a little bit about this, and I'm going to let Ryan kind of hop in. I can tell you that we scanned the entire campus as far as the location of the drive-up testing. Um, you know, Putting it where it was not ideal. I would completely agree. But in order to comply with some of the state regulations and have some proximity to the services that we need to provide out there, and scanning the entire campus and the layout of our campus, that was really the only place we could have put it. What we did, and again, I want Brian to comment on this, was we tried to improve the traffic flow with security out there and create a lane so that the cars would stay, to the right and clear the way for the ambulances to come in to the left. But it wasn't perfect, Justin, and you are totally right about that. Brian, I don't know if you want to add to that.
So yeah, I'll add to it. So the tough part, like you said, was DPH. We asked if we could put it in different areas, and they pretty much told us that they wanted it right there because it was so close to the ER, and for supplies and everything that we needed, bathrooms were all right there. When you were having issues with the driving, did you notice if it was in the beginning or is it still currently now? Because if it's still currently now, it's something we could definitely fix. We're trying currently to make them hug the corner a little bit more now so that they're not going out into the intersection. Plus you're with Middlebury too, right? So you got the wider ambulance. Yeah.
So it was probably about 4 to 6 weeks ago. And I think I actually had to dodge around you standing out there when I came in. So it wasn't like it was a terrible issue, but if you had multiple ambulances arriving at one time, you probably would have had ambulances just stopping on the hill.
Yeah, and jumping the curb is not really comfortable for your patient either. So,
correct.
I'll look at it. I'll check it out on Friday because we're open again on Friday. So I'll make sure that it's nice and tight there. For the
Justin,
future.
I know that in the beginning, when we first opened up, we had lines of cars that went all the way down from our entrance in Robin Street down to Watertown Avenue and started wrapping up Watertown Avenue. Nowadays, the traffic isn't nearly as much, so I think now's the time for us to address this and see what we can do to make sure that doesn't happen. Anybody else? Any other questions? Any other concerns? Any other feedback for us? Did you find this presentation helpful?
I thought I heard someone else about to say something.
So Jeremy, I'll turn it back to you. If you all will know how to get a hold of me. I think you can get a hold of me through Ryan or Jeremy. If you think of something later, shoot me an email. We'll get back to you. If you have any other feedback and you didn't want to say it in this meeting, then again, please feel free to write to me directly, and I will respond to you. My colleagues that are here know that I tend to answer email at all times of the day or night. So I will get back to you. You have to give me probably 24 to 48 hours at the most. But I want to thank Jeremy and Ryan for setting this up, for inviting me to speak. I hope that the presentation was helpful to everybody. That you got a picture of sort of what was going on and what we learned out of it. And I have to tell you that every day, none of this is out of our minds. We see and keep an eye on what's happening in the rest of the country. And I think if I could say something to everybody out there, wear your mask, keep your distance, practice good hand hygiene, because I think that the moment we get complacent about any of this is the moment we're going to end up being Florida or Arizona or any of the other hotspots that exist today. So thank you very much. Jeremy, it's all yours.
Thank you, Mark. And thank you all for joining. And for those of you who would like to share this, we're going to have the video available soon. So please let other people know that they can share it. And it was really important for us to put out this CME and talk about some of the things that maybe you didn't know were going on behind the scenes, and that EMS was a major consideration when we were making our plans and doing our things, and understanding that our EMS providers are literally on the front lines of this thing, crawling into people's houses and in overturned cars and stuff like that, and exposing themselves potentially to this disease that what you were doing in the field was certainly not lost on us at the hospital, for sure. As an EMS provider myself, it was definitely a challenge. As we move forward with this, we hope that all the lessons that we learned will be fresh in our minds should we ever have to go through this again, and it'll be a little bit less bumpy and a little bit more streamlined, and the communications will be faster and the processes will be faster. So that's the hope. I thank everyone for joining. Again, if you have any comments or questions or concerns, you can email me or Mark or Ryan. And I'd like to thank everybody for joining tonight. And this video will be posted on our website as soon as we can get it.
Jay, I have one more thing to say too. This is right from ESF8. So supplies are extremely low right now. And I know that the different caches around our area. So Bethlehem and Goshen, where we pick up our supplies every week, those are going to be closing soon. So whatever you guys have for PPE, try and conserve it. If you can get your hands on those half face mask pieces, try and get them, because all this stuff is we're not going to be able to get our hands on it. I could tell you from the hospital side that we're having trouble getting supplies. So if you guys see something out there, don't wait around. Buy it as quickly as you can. I know that the state is building a stockpile, so that's one of the reasons why we're not seeing the N95s and all that stuff come out currently. So if you can get supplies, get them.
All right. Thanks, everybody.
Thank you very much.
I would tell you to drive home safe, but a lot of you are home. So have a good night. Enjoy your families and stay safe.
Thank you, everyone.